consideration for the final restoration. Ensuring both adequate retention for the final restoration and maximum resistance is called anchorage. That is both the retention and the resistance. So the first thing I'm going to discuss is maintaining tooth vitality. And what I mean by maintaining tooth vitality is basically before you start anything, you have to consider if this tooth needs endo, if the caries on this tooth can be remineralized, or is it active caries. The previous practice of just drill and fill has to be reconsidered, because we don't have to drill into any fissure, pits and fissures. We don't have to surgically remove any decay unless it's necessary. So the first thing we need to know, if the caries are active, then we restore them. If there are more conservative approaches we can take, then we'll go with that approach, because we can keep the tooth vital this way. So initial operative intervention has to be a part of the treatment plan, which is now reserved for active dental caries only. Importance of operative and restorative quality for maximum longevity and reduction in re-restoration frequency. The use of two-stage deep caries management. By that, I mean we don't necessarily always have to remove all the caries in order. This way we can protect the pulp. So what we need to remove is, first of all, we have to identify caries dentin, and then we have to make sure that we remove, this is a common practice now, we remove as much as we can from the caries dentin without exposing the pulp, if possible. And then this way we achieve avoidance of pulp exposure. Now, this is a more conservative method that can maintain pulp vitality and avoid root canal treatment and weakening the tooth. Another thing we can do is repair techniques. Repair techniques, what I mean by that is, if you get a defective restoration, you don't necessarily have to remove the whole restoration. You can only replace the defective part if the rest of the restoration is okay. Again, you avoid irritating the pulp and you maintain the pulp vitality. Post-operative sensitivity is another reason where we always end up in endotherapy. If we can reduce post-operative sensitivity by, for example, two-step self-etching primer, using self-etching resin cements, and obviously using coolants and doing the appropriate preparation, you can avoid going into endotherapy. Next, we're going to talk about is the failure of endodontically treated teeth. Now, this might be surprising for you all, but only 7% of endo failures are from the actual endo procedure. Most of the endo failure comes from unrestorable tooth fractures. So the basis of long-term prognosis comes from an appropriate filling. The other reason for endo failure is periodontal problems. Now, failures can be due to less than optimal endodontic therapy. Yes, that's, as I said, that's 7% of endodontic failures, but also the most important thing is unsuccessful restorations. Now, all failures were due to fracture of the natural coronal tooth structure and appear to involve either uncrowned teeth or crowned teeth without definitive anchorage. Anchorage, again, is resistance and retention. Teeth with crowns showed longer clinical life than non-crowned teeth. This is something we all know. Approximately 10% of all failures were due to root fracture, and all root fractures pivoted from the apical end of the root of the post, which means they were non-restorable and needed extractions. Another reason for endodontic failure is bacterial recontamination of the root canal, and most of that was due to the loss of temporary restoration of or leakage or inadequate final restorations. Now let's discuss the need for extracoronal support. Do we always need extracoronal support? For posterior teeth, yes, most of the time we do need extracoronal support. We need to crown the tooth. For anterior teeth, not necessarily. Sometimes we do, sometimes we don't. It depends on how much tooth structure was lost. So let's start with posterior teeth. Endodontically treated teeth are significantly improved with coronal coverage. Placement of a crown to encircle the tooth can increase the resistance of a posterior tooth to fracture. For the presence of a crown was more important than the type of foundation restoration, although it was noted that teeth with post demonstrated better survival. For anterior teeth, substantial loss of external coronal tooth structure if substantial loss of external coronal tooth structure has occurred, then yes, we do need a crown. And if the tooth is anesthetic and bleaching, internal or external bleaching didn't work, then yes, a crown can be considered, or a veneer. Now, I have some more notes on this. Okay, so endodontically treated teeth without crowns failed at a 6 times greater rate than uncrowned teeth. So that is something to consider. Someone just scraped my presentation. Okay, we can move forward. Okay, so now the importance of the remaining tooth structure. This is a point I'm going to continue to repeat, so bear with me. What is a ferrule? It is the circumferential ring of sound tooth structure that is enveloped by the cervical portion of the crown restoration. A minimum sound dentin of 1.5 to 2 millimeter is required between the core and crown margins. The ferrule provides bracing or casing action to protect the integrity of the root. The fracture resistance of post cores increases with the presence of retained coronal dentin, and the longer the ferrule, the higher the fracture resistance. When we don't have adequate ferrule, what do we do? If we do choose to restore the tooth, we can increase the ferrule by surgical crown lengthening, forced orthodontic eruption, or subgingival preparation. With the subgingival preparation, we should keep the temporary on for a longer time to allow reestablishment of the biological width. Now, the reason the ferrule is so important is because the fracture resistance increases with more coronal dentin available, right? The longer the ferrule, the more the fracture resistance. So again, the consequence of inadequate ferrule will have catastrophic root fracture, cement failure, and post-loosening and post-fracture. Okay, so criteria for post placement. Previously considered to provide reinforcement of the root, it is now recognized that the post may help reinforce the remaining tooth structure, but post preparation can significantly weaken the tooth. General guidelines for anterior teeth: if no crown is required, then a post is not necessary. However, in this case, we might need internal or external bleaching. And as we know, bleaching can cause resorption. So just to reduce the risk of resorption, the use of modified glass ionomer restoration at the base of the pulp chamber will prevent resorption. However, if a crown is necessary, then a post is generally necessary. For posterior teeth, molar teeth with an adequate pulp chamber do not require a post, and molar teeth with inadequate pulp chamber require a post. For premolars, maxillary premolars generally require a post. Also, minimal enlargement and shaping of the canals and maxillary bicuspids is very important, and we have to consider the anatomical anatomy of the bicuspids, especially the thin mesiodistal dimension and the proximal root invaginations in the maxillary bicuspids, because this is where most fractures happen. Now, for mandibular bicuspid, requires independent consideration. This depends on A, the amount of tooth structure left, and B, if the cusps are steeped and if there's a high function on the tooth, on the mandibular bicuspids, and if they will be used as abutments. Now, criteria for post-placement. For anterior teeth, it is better to complete the crown preparation, see how much tooth structure we have left, and then decide if we need a post or not. For posterior teeth, generally we use the largest straight canal, the straightest canal, to utilize the post. That is, for maxillary molars, it is the palatal, and for mandibular molars, it's the distal. Post preparations are contraindicated in curved, narrow mesial canals of mandibular molars and mesiobuccal canals of maxillary molars. Now, for the maxillary bicuspids, this is the common site of endodontic treated tooth failure. This is because of the slender cervical circumference and concave mesial anatomy. And for the mandibular bicuspids, they frequently function as small molars with short crowns and less steeply inclined cusps. They receive more vertical and less shearing force. The need for extracoronal support, as I said, will be based on how much tooth structure is left and the function that is anticipated. Now, post selection. When we choose a post, we need a post that has high strength to prevent cervical fracture, high elastic limit to prevent distortion, and obviously adequate radio opacity. Now, the type of post, we have a lot of different types of posts. Metallic posts are, I believe, the first posts that were used. And then we have non-metallic posts, which are carbon fiber posts and tooth-colored posts. And then tooth-colored posts are zirconia ceramic posts and fiber reinforced. We also have composite posts. Let's start quickly. We'll go over these real quick. Metallic post, we have cast and prefabricated. There is no difference in superiority when it comes to cast and prefabricated. The thing with prefabricated is that they conserve more time and they're better cost for the patient. So I would say they're better for you and the patient because there's no difference in superiority. Now, for non-metallic posts, let's start with the carbon fiber posts. They have no radio opacity and they're black in color. Both are disadvantages. They're also quite stiff and they're very comparable in stiffness to metallic posts. Retention of composite core to carbon fiber post is lower than that to metal post, and the retentive failure at the post-cement interface has been documented. Next, we move on to tooth-colored posts, starting with zirconia ceramic posts. They're white, radio-opaque, and strong. They have a modulus of elasticity higher than stainless steel, and modification can only be done with diamond discs. Otherwise, the strength will be compromised. Next, we move on to fiber reinforced and composite posts. They're not as strong as all the previous posts that I mentioned. And that's why they should be used with caution, especially if we have very little tooth structure remaining or we have high occlusal forces present. We cannot use them if we have less than 2 to 3 millimeter of supragingival tooth structure, or if we have parafunction or a deep overbite. Glass fiber reinforced posts have less stiff fibers, which is both a disadvantage and an advantage. They're more flexible. However, that flexibility can cause movement of the core, which can lead to failure. Next, we move on to post-space preparation. Optimal post-space preparation is achieved by use of non-end cutting rotary instrument, minimal canal enlargement, diameter 1/3 root width or less, length at least equivalent to crown height. So we shouldn't be using short or extra long posts because they increase root fracture, especially short posts because they lead to greater stress at the coronal aspect of the canal and they're more susceptible to dislodgement and causing root fracture. So normally as a guideline, we use 7 to 8 millimeter post length. Next, we have to have 4 to 5 millimeter of obturation material remaining and post modification to fit the canal, passive post design and placement, and adequate ferrule, as I mentioned earlier. Now, minimal canal enlargement is very necessary to reduce further weakening of the tooth. And sometimes we have to adjust the post to fit the canal if the drill matched post dimension do not seat to the intended depth. Now, failure to appreciate root anatomy or pulp chamber depth, or also using incorrect burr angulation can cause failure. So we have to watch for that when we are doing a post-space preparation. Also, as a general technique, we can use Gates Glidden instrument, no wider than the canal width, and we also use piso burrs as instruments with the least invasive preparation. So that's for post-base preparation. Now we move on to cementation. Okay, so the purpose of cement is to secure the retention inherent in the design and to ensure a seal against micro leakage. Cements are best introduced to the canal with lentulospiral, and the post should be also coated with cement. Adhesive cements of post can both increase post retention and reinforce the tooth. Effective bonding of the post can also reduce dentin stresses. In fiber reinforced epoxy posts, it decreases water absorption, which can decrease their strength. Another thing we should keep in mind is bonding can be impaired when we have remnants of endodontic sealers. So that's why it's recommended to clean the canal surfaces with alcohol or detergent. Generally, zinc phosphate cements have high modulus, ease of use, and have withstood the test of time. Resin cements can provide a significant increase in retentive strength. However, they should not be used with less. They should be used for post situations with less than optimal retention. Okay, now treatment planning. This is the most important part before we do anything to the tooth, whether it's already endo restored or we're about to do an endo on it. Treatment planning is the most important thing. So we have to assess the overall situation of the tooth, how much tooth structure we have left, and if whatever treatment we're going to do is going to have a good long-term prognosis. So we have to make the decision based on how much periodontal, what's the periodontal condition and bone support, what is the root length, what is the anticipated functional demand, and the completeness of the remaining dentition, which means do we have adjacent teeth or not? Because the prognosis of endodontically treated teeth are better in a complete dental arch because of the stabilizing effect of mesial and distal proximal contact. Teeth without adjacent teeth tend to become more mobile because of periodontal bone loss. So these are all things that we have to assess before starting or initiating any therapy. And another thing we should consider is also integrated implants due to the predictability and the success of these treatments. So if you feel like the tooth is hopeless or have very short-term prognosis, then maybe it's something you can suggest to your patients. Okay, finally, in conclusion, a major objective in dentistry is maintenance of tooth vitality. Pulpless teeth are weaker and have a lower prognosis. Pulpless teeth require restoration that both conserve and protect remaining tooth structure. Non-axial forces, abutments, teeth without adjacent teeth, and those with reduced bone support are most deleterious. Remaining vertical coronal tooth structure, the ferrule, which I mentioned over and over again, is paramount to resist fracture and is more important than post-design material or loading cement. The clinical success depends on application of sound biomechanical principle to the specific tooth and clinical situation. And that's the end. Thank you guys for bearing with me. I haven't done a presentation since graduation, so I hope this wasn't terrible.
You did an excellent job, Dr. Lubna. It was very informative, short, and sweet. And you guys all have the article where this information came from. I highly encourage you all to read it because it has more details. The recording will be shared, although I think I missed the first few seconds, but it will be shared. If Dr. Lubna can send me the presentation, that would be great. So I'll include it with the email with a recording. Now, if you have any questions about the presentation or endo questions in general, we do have the next 30 minutes or so. You can type in your questions in the chat, and I have Dr. Lewis with us, who has very kindly accepted to be here to answer your questions.
Good evening. Can you hear me?
Yes, we can.
Okay, perfect.
What did you think of the presentation?
I was going to congratulate Dr. Lubna. Very detailed, very interesting.
Thank you.
Very nice seeing Bernie Sanders there in the chair. Like he's all over the place Of course, he cannot be missed at the dental office, and wearing his mask, of course. So I very interesting. I actually if there's no questions, what I would like to do is kind of add things that will be very important to kind of
That would be
remember.
great. It's your time to send a message to the associates.
Yes, yes. It's a good time to bring this channel of connections and discussions that we all can benefit from. Things are very important. First is that as soon as the root canal treatment is done, the sooner you get the restoration, the better the prognosis. So I can imagine many scenarios, and probably you face this every day. That's why I like to bring this to the clinical level, because there's a lot of information, there's a lot of research, but even though you probably will think that we know a lot about this, no, we don't know a lot about long terms. That's why, and probably Dr. Lubna actually keeps finding that all the time they're saying the most important is the remaining coronal tooth structure, the ferrule effect, and covering with cuspal protection. So those three things, as right now, we know for sure they're critical in order to keep a tooth in a long term. There's a lot of new technology, designing new posts. You don't know how much the industry is putting money into research to every year come up with patents for new posts, for new materials, but none of them are being tested. They've been tested, let's say in vitro, but that doesn't sometimes relate to the clinical outcomes that we're expecting. And sometimes what happens is that a lot of those products come up in the market, and by the time that we end up seeing that there's no difference, or it really can happen, that can be the opposite, that actually is a very bad material, we end up being using it for 4 or 5 years. So keeping in mind these three things, it's very important in order to get like good results. Okay, having said that, how quickly should we restore it? Ideally, as soon as possible. Sometimes, yes, there's situations when the patient is still tender and we wait a little bit, but there's things that we can do in the meantime. We can reduce occlusion. There are cases in which I tell the referrals, we can do a temporary crown and keep the tooth protected, because it's very important. And that's that study that Dr. Lubna mentioned about seeing that the long-term prognosis of the tooth relies more on the restoration than the root canal. The quality of the root canal treatment it's true, but it has to be taken partially. Like, you still need to have your root canal with quality and expected to have the canal completely disinfected and at least sealed properly to avoid recontamination. Those principles cannot be changed. But what we have seen is that even in poor quality root canal treatments, if they have a good restoration, we have seen them that they do last quite some time. So the win-win will be having a good restoration, a promptly good restoration, good sealed, and a good quality root canal treatments. That's what we have to aim. When we say that a good restoration, as you can see in practice, you see probably a lot of cases that they come in with restorations done by other practitioners. So we have to end up deciding, am I keeping this crown? Does it seal? Is the quality of that root canal treatment adequate? And those are situations that we face. And sometimes we don't know. We have to ask questions like when it was done. Do we have access for x-rays of that root canal treatment? Sometimes we have to say, well, I didn't do that root canal treatment. I don't know the condition of that root canal treatment. So it's like seeing a picture or seeing an x-ray, but not knowing specifically if it's infected or not. So we have to rely on and to asking the patient a lot of questions in the history. I see patients say, oh, I had that root canal treatment done 20 years ago. But when you keep asking them, they say, oh, but you know something, 10 years ago, I had a lot of pain and they prescribed me some antibiotics and I had swelling and it went away. The immune system, It's wonderful. I have to say that. Sometimes we see patients in perfect root canal treatments having a lot of pain, and we see patients with root canal treatments that we say like, how come this has lasted 10, 20 years, and we don't even see a radiolucency. So yeah, we have to be very critical of those restorations and those root canal treatments when we're treatment planning. And like I said, there's a lot of things. For example, and I was talking about how quickly restore and how to protect the tooth. We usually tend to tell the patients try to not chew on that side to avoid fracture. It's very common having fractures from patient going with temporary fillings, and then coming for the final restoration, and the tooth is already cracked. Sometimes it's cracked and the patient doesn't feel anything, and then we restore it. And that's the thing that later on we end up seeing that periodontal defects gets to be formed, and we see we end up finding that out through with a perioprobe, probing around and finding out that we have that, or sometimes when the patients specifically indicate that he has pain. So there's other things. For example, when we're putting a temporary filling and the tooth needs to be restored. Now in the endo programs, we're not that crazy with cavit. There's some ideas of trying to put at least 2 different layers. Like for example, put cavit and then on top put something that wears off less than cavit. For example, REM or glass ionomer. Or people don't put cotton pellets and then try to, some endodontists will restore it right away and send it a restore to the practitioners. There's a tendency of trying to have the endodontist to be more involved in the restoration, the same as doing the post space. Sometimes we don't like to do the post space if we know that the patient, it's not going to be restored right away, knowing that we have to leave inside anyway a cotton pellet and a temporary restoration. But there's also options in which we can put something like a resin as a temporary restoration if we know the patient is going to take some time to restore it. We have to understand that the tooth is more fragile, like the root canal treatment is more fragile because the tooth itself has lost tooth structure from cavities, from previous restorations, from the root canal itself. And then we add to that the denting, it doesn't have a vital pulp. So the free water inside the tooth plus the water that's bonding with the organic structure is missing in that tooth. So when we put pressure onto the tooth, the chances of breaking it is higher on a root canal treated tooth. So that's why the importance on having on your patients that have root canal treatments in premolars and molars to emphasize the need for crowns. I tell them all the time to the patients, if you want to keep it for long, go with a crown. If there are patients in which they say, well, I'm going to try to be careful. Yeah, we might end up seeing them 4 or 5 years later and they still have the tooth. But usually the studies show us that in a 10-year evaluation, we see that those patients develop usually fractures that end up needing to be having the tooth removed. That's another thing when you're talking to the patients. Sometimes they might say, well, if a piece of the crown cracks, I can have it restored with a crown later on. We have to tell patients that usually when we have a tooth that is restored on an MOD or on just occlusal surface, and it has a root canal treatment, usually when it fractures happen or usually it ends up being extracted because there's the extension of the access opening into the pulp chamber in the canals, when we actually apply forces, end up having a crack that extends usually into the roots. And like I said, we're not finding it out sometimes usually by radiographic images or by having the patient develop some swelling. Sometimes when we see those fractures, we see patients coming with more than 1 or 2, 3 draining sinus. In this case, it's called a fistula. We sometimes see those fractures that they end up having more than one, sometimes even in buccal or lingual, or even buccal, they might have 1 or 2. We might see because of the different pockets of infections. Things that are important too, if you're doing a post space, try to isolate, like try to keep the area without having contaminations. It's very important. If you're using a resin sealer to bond your post and your crown, which they're very good nowadays. Nothing against the zinc phosphate. It's been tested through times. It's very good. But we see a lot of advantages of also new resins for restoring, cementing the post and the crowns. You have to try to avoid having contamination because that's going to impair the adhesion of the post. The same is if there's any remaining of gutta perca, what Dr. Lubna says, try to clean all that with alcohol and try to make sure that the post gets to be inserted passively and the sealer is going to help out. An important thing is try to use dual cements because of the lights might not get to cure deep in the canal, so we have to rely on the chemical curing of those sealers too. When we are, I've seen cases sometimes of patient coming in and say, "Oh, I had a root canal treatment done," and we see a post. Probably you have seen that, a post, and we don't see a gutta perca in the canal. And we were like, "Oh, how come they put that post and they didn't put a gutta perca in there?" Most of the cases is that when they're doing the post space, they remove everything and no x-ray is taken and the post is cemented and the crown is cemented, and we are the ones that end up finding that out and telling the patient, "Oh, you have a tooth with a root canal treatment. There's no root canal treatment there, and there's a post cemented." So that's why when you guys prepare for a post, don't hesitate and take an x-ray and kind of see if you're at least leaving the minimum of 5 millimeters of gutta perca in order to have a proper seal. I think we're having a question. I don't know if I'm talking too fast. You guys stop me if I am.
No, you're doing great, Dr. Lewis.
Doing good.
I will read the question. So, in case a patient came after they did an RCT and they came with a broken tooth and the RCT is exposed, what is the right treatment plan or what's the protocol? I guess the question is about how much time do we have before it's too late and we have to redo the treatment?
That's a question that we get all the time. Dr. Martin Trope and Dr. Torabinejad, one in Trope in North Carolina, I think, when he did the study, and Torabinejad is in Loma Linda University in California. They did in vitro studies, and they come up with, like, in 16 days of exposed gutta perca with saliva, we get the bacteria in the canal.
In 16, that is 1/6.
1/6. Even 1/6 in 16 days, we see that there's contamination even up to the full extent of the canal. In those vitro studies, in vitro studies, you have everything very well controlled. You have like a more amount of just one specific bacteria. So we have to, when we see the literature, we have to check very well, and we have to see what can we actually infer from those studies into the clinical scenarios. At least the consensus is that you cannot have like leakage, that that is leakage for more than 3 months. But that's for most endodontists will be too long. But sometimes we have to see what we consider exposure. If the patient is coming with a fracture of the crown and the gutta perca is exposed, and it's been like that exposed for, let's say, 2-3 weeks, yeah, everyone will feel not probably comfortable and say like, okay, let's redo this. But we also have to evaluate situations. If redoing that root canal might pose, let's say, a risk of like causing more iatrogenic, let's say it's a very curved canal, and redoing that will pose the risk of like losing the tooth. Sometimes we might just remove coronally some of the gutta perca, disinfect that area and seal it again and monitor. And if it's needed a retreatment, that at that moment it can be discussed with the patient and decided if it's going to be a surgery, an endosurgery, or any other alternative. If redoing the treatment, it poses a risk. If it's a straightforward root canal treatment and we see a accumulation plaque around that exposure, I would recommend for the sake of like just redoing it quickly and disinfect those canals instead of like later on put a crown, and then having that, because coronal leakage is a cause of failure for root canal treatment. So we can, and gutta itself doesn't stop it. Having said that, there's some sealers which are resin based. We use them, for example, H plus or now bioceramic sealer, that they might delay the coronal leakage. And that's why we stand and say, well, probably I can spend a couple weeks if it's not a frank leakage, if it's probably just leakage around marginal openings from a crown or a temporary crown. So I would say it's more based decision on the case, but if it's more than 2-3 weeks, probably I'll prefer to have it redone. If it's something that it falls up from one day within a week, no, I will not probably remove it all. If I see that the root canal has good quality.
Okay, that's great. I think that answers the question. There's another question from Dr. Pahal. If a patient comes in with a root canal treatment with unsatisfactory obturation midway of root, for example, restoration is adequate, the tooth is asymptomatic, and there's no apical radiolucency, what is the protocol? Do we monitor it or do we refer it to an endodontist?
That's a good question to emphasize the purpose of the treatment. If the patient is coming, and I'm gonna go step by step. If the patient is coming with a non-satisfactory obturation, it's not adequately obturated, and we're not seeing any apical radiolucency in our periapical X-ray, the patient does not have at the moment any symptoms or has not expressed any symptoms. What is the protocol? The protocol will depend completely on what's the plan for that tooth. If the tooth is planned to receive a new restoration, the protocol will be redo that root canal treatment. If the tooth will not, it's not planned to have anything done, and we're just finding that out through an X-ray, it's just monitor, because what are we going to improve? What's our aim? To improve the radiographic aesthetics of that root canal treatment, like making it look better on the X-ray, but are we actually providing any benefit for the patient? Are we actually eliminating anything? Are we actually eliminating any symptoms? Are we actually aiming it to produce any healing? Because at that point, even though it might not be technically acceptable, it doesn't mean the patient it's not having the periapical tissues healthy. So if we're aiming to redo the root canal treatment or improve the root canal treatment, we have to have a reason. And the reason will be like patient center, which will be like aimed to produce a healthy environment for the patient to heal. If there's no infection that we actually can see, and there's no plan for new restoration, there's no need to redo that root canal.
Okay, thank you. Dr. Marjan.
Before I say something.
Sure.
But all that explanation that I just said, we have to tell the patient. Like once we see on the X-ray that the root canal treatment doesn't have the technical quality, we have to explain the patient as the moment I'm seeing that it's healthy. It's not technically as today as we wanted it to, but it's functional. So patient needs to be aware. If at that moment the patient is aware, when anything happens later on, let's say that swelling or pain or any signs of a recurrent infection, the patient will know and will relate it to that. So that's something that I want to emphasize when we're not finding cases like that.
Excellent. So inform the patient and keep it in your record so that yes. We're protected and there are no surprises down the road.
Yes.
There's a question from Dr. Marjan. How are you, Dr. Marjan? I hope everything is good and your baby is healthy inside you still. Okay, so overextension or underextension of gutta perca in a necrosed tooth with asymptomatic apical periodontitis. Which one has the worst prognosis?
Yeah, that's a pure endo question. Um, yes, when we're having a case in which we have a periapical lesion and we're doing the obturation, more critical than the extension of the gutta perca means that it's go beyond the our apical terminus, the our apical preparation. Let's put in those words. There's so many words to define like technically how the root canal ends. That's a specific area, the foramen, the radiographic apex, the histological apex. So the extension of the material, it was more critical that if we're having the extension of the material, but we don't have the area around the apex sealed. So having the root canal overextended in the studies have shown a bad prognosis if we don't have the surroundings of the apex sealed. So if we have just an extension of the gutta perca, but the canal is very well sealed, we have seen that the success rate it's within acceptable. When we're having a root canal short and we have still bacteria there, it's not properly clean, and we see a persistent infection there. It all depends also to on the previous diagnosis on the tooth. If we're talking about a vital tooth, if we're talking about a necrotic tooth. In this case, that we're having asymptomatic apical periodontitis, we're assuming that we're having an inflammation of the periapex, but not necessarily we have to have a large lesion or a small lesion. So I will say that when we see prognosis, usually what we have to aim at that aspect is try to keep the material within the canal contact and have it disinfected up to that point and have it sealed. If it goes beyond, we have to, if we're not canal retrievement, we have to monitor. If it goes beyond, but we're seeing that we're having gaps or spaces around that material. And when I say gaps or spaces, I wish I can have like a slide in which I can give you more details about that. Let's say, for example, you're obturating a paddle canal and on an 1/6, an upper 6, and the canal is very wide, and all of a sudden the gutta perca went beyond. But I can even see gaps into the gutta perca, like the gutta perca, it's not actually sealing around. That's going to be a very bad prognosis for that case because the material went beyond. The material, it says that goes beyond, it's not that much the problem. It's the problem of not having the canal preparation sealed. Why? Because then we can have fluids going in, and then the bacteria has source of nutrients to actually keep persistent, have a lesion to be persistent. So that's the most important part. If we have an overextension and it's sealed, the protocol is to actually monitor and very likely apical surgery if it needs to be corrected.
Thank you. Dr. Pahal is asking, what's the success rate of endo retreatment generally?
Generally, the endo retreatment is around 86%, 88%.
And the initial treatment?
The endo retreatment, it can go from that. Usually, we tell patients it goes from 86 to 88%.
What about initial treatment?
Initial treatments can go up to 96%. We can go from 92% to even 96%. Nice. So we tell the patients that, and when I'm saying this, it's following the proper protocol on which we got those results. We can say that that we're using disinfectants, that we're keeping our working lens, that we're disinfecting the canal or properly eliminating the pulp tissue in vital cases. We have to around the studies that goes from 92 to 96. In retreatments, we can go lower, up 86, 88. Yep.
And along the same lines, the success rate of the surgery, of root end surgeries?
Root end surgery success has changed. That has changed with the new techniques, with the microscope, with my ceramic sealers, microsurgeries, all the instruments, and it's getting as high as 94%, 92
Wow,
and
that's nice.
94%. So if you're trying to attend to do a root canal treatment, let's say a vital tooth, and eventually it falls into needing to have a retreatment and needing to have a surgery, when you see all the high percentage of each of the options, we're seeing that, yeah, the chances for keeping the tooth is very high. The surgery has increased so much that it's changing some protocols. It's more conservative to actually do a retreatment, but there's some treatment plans in which they're going directly into do surgeries instead of the retreatments based on the chances. If the post is going to be very complicated to remove, or the chances for weakening the tooth too much, there's no second thought of going immediately and try to do a surgery because of the high success rate nowadays.
Nice. If a tooth is suspected to be cracked, how long does it take to show any changes on the X-ray?
That depends on the location of the crack. That depends on the like the extension of the crack. That depends on the also on the immune system of the patients. The patients that they have the crack, and because if the tooth is restored, it's not advancing. It takes time to see it, but it does have very good questions. The problem is that we don't know when the crack happens. So in order for us to follow up and see when it will show up, but sometimes what we have is patients that they say, I recall when I crack into something. And from that, it's more anecdotal. I've seen patients saying that, I cracked, let's say, on Christmas. I was eating something. And then from there, you see that the patients start having some pain. But from when to see it radiographically, it will be when bone destruction shows up. And that's going to be it's going to vary a lot depending on the patients. By the time that we end up being able to have a probe to go in and probe a perio pocket, it's because there's being detachment. It's usually that the crack already is being contaminated. In some patients can be fast, but I've seen in some patients takes long. So there's not a number for that yet.
Now, assuming the question was about a cracked tooth with a root canal that's already done, what if it's a cracked tooth, period, there was no root canal done? Is it contraindicated to attempt a root canal on that tooth? And provided that the patient does have pulpal involvement and pulpal symptoms.
So in this case, it's a vital pulp where we have a crack that we're suspicious that extends into the root?
Yes.
That's the question? Okay. So in that aspect, the microscope is very useful because that's what we have as a standard of care right now. We do the access opening, we're suspicious there's a crack. If the crack extends into the root, it's that when we consider that the tooth should be removed. If the cracks, let's say it's in mesial or distal, but stays within the clinical crown, we're able to do the root canal treatment, but we have to restore the tooth right away with all the guidelines that we just said. If a rule of fed, have a cuspal protection like a crown, and we monitor the patient. But if it gets to be addressed right away and restored right away, it has the high chances, a good prognosis to be safe. If it's necrotic, it's like I say, also it's extending into the root, less chances to work. They are cases that are being managed, but it's not still standard of care. When I'm saying this, we have to take it carefully because we have seen in the literature cases of try to repair fractures surgically. But it's like I say, there's things that you explain the patient what you're trying to do, but it still is not something that is teachable in any graduate level or it's considered standard of care. It's something that can be tried if there's not any other option. But like I say, still not standard of care. Right now, It's actually here in the University of Toronto with Dr. Anil Kishen. They're working with nanoparticles to try to remineralize or try to kind of like seal those fractures. Those are more lab studies, still not commercial, but it's I've seen the research on that. It's very very promising of trying to fix those cracks, those fractures with nanoparticles. We're still in a very very early stage of trying to do that, but it's very promising, and I will not be surprised within 5 years or 10 years that we're going to start seeing that.
In an emergency pulpectomy, is it enough to, oops, there was a question by Dr. Bahal that I missed. Okay, we'll answer it. And then another one by Dr. Basso, and I do have one.
Okay.
Okay, so in an emergency pulpectomy, is it enough to work to length with size 20K file, or should we prepare the canal with rotary instruments to just pre-obturation?
Ideally, it's better just to prepare the canal as you were going to obturate. Okay. If you can use those extra time, if you're going to aim it to finish at 25 or 30, whatever is going to be your preparation, it's better because you're making sure that you're removing most of the pulp. And actually would be ideally to avoid more post-operative pain or flare-ups.
Yes. Dr. Pahal is asking, what are the reasons for lower success rate from initial to endo retreatment? Is it the removal of more dentin, therefore the fragile tooth?
If like what's the reason for lower success rate from initial to endo pre-treatment?
Yeah, so the retreatment has lower success rates than the initial. What would be the reason for that?
The reason is that in an initial treatment, we have bacteria. We have colonies of bacteria. Depending how long they're being in the canal, we can have a very resistant biofilm covering the walls of the canals. In a retreatment, we have found different colonies of bacteria. Are bacteria that actually were more resistant to the previous treatment. So we're seeing that the prevalence of the bacteria that we see in retreatments, it's more, it's harder to actually eliminate from the canal. That's why in a retreatment, we have to emphasize more in re-cleaning and sometimes use medication between appointments to make sure that we're disinfecting properly. Also on a retreatment, we have to, sorry? Here we, yeah, I got disconnected. Are you guys hearing me?
Yeah, yes. Dr. Lewis, yes, we can hear you.
Hello?
Yeah, we can hear you.
Hello? I don't know if they're hearing me.
Okay, let me mute.
Okay, hello?
Okay.
I'm not hearing.
You are not here. We can hear you.
Hello?
We can hear you, Dr. Lewis.
Hello? I don't know. I'm not hearing.
1 second. Let me call.
Hello?
I will be calling Dr. Lewis.
Hello.
Is there any way that I can write on the screen that we can hear him?
I texted him, but
I did text him as well, and I'm calling
Hello.
him. Can you type it in your presentation, Dr. Lubna?
I'm not
Sorry.
that tech savvy, but I'm gonna try.
Sorry, I'm hearing now.
Okay, perfect.
You're hearing now? Okay,
Sorry.
great.
It's that my headset, my son turned off his iPad, so all of a sudden I was hearing cartoons or things like that. So like, what's his?
Oh, no
And
worries.
I was like, "Why you're awake?" Oh my god. Oh my god. But I don't even know what I was answering, but I was
So
something
we were
related to
talking
endo.
about the bacteria and the microbiology of the retreatment and how
Yes,
it's more
the retreatment. Also, in the retreatments, we have to try to overcome sometimes ledges. Sometimes it's obturated short. So, but the most important thing is we have to try to correct what it was actually not achieved on the first treatment. The chances for being successful, like I said, the elimination of all that bacteria has made it's more difficult. So in the outcome study, it has shown to be lower in terms of, like, for example, in vital cases or cases that you have done initially. Yep.
Okay. Another question by Dr. Bassel. If a patient presents with only sensitivity to cold and crack was the reason, pulp tests were normal, what should we do at that point? Would a crown be enough for a treatment of choice, or should something else be done?
If the patient is having only sensitivity to cold, we usually try to manage that in the most conservative way. Try to put some varnishes or try to have the patient use sensitivity toothpaste. If all that it's not working and the patient is actually being disrupted his life with having that sensitivity, is that we start thinking about like even root canal treatment is an option, or if in that case a crown is needed, then because of a crack, then yeah, it's indicated to do a crown. But like I said from the beginning, it's we have to try to be as most conservative as possible.
Okay. Now, my question is about rubber dams. So, from what I remember in U of T, it was contraindicated to start a root canal if we cannot place a rubber dam on the tooth. What are your thoughts on that? And what can we do to be able to rubber dam the tooth rather than just using cotton rolls to isolate when we're doing a root canal?
The standard
I mean,
of
it's the
care,
standard of care, right? So
standard of care, it's root canal treatment needs to be done under rubber dam. There's there's a lot of different ways to place them. There's a lot of different materials to place them. That if it's difficult, there's so many different type of clamps. There's so many different types of techniques. There's even lectures specifically just to isolate. I don't know if there's a book specifically. I know there's booklets specifically of how to do isolation, but it's the standard of care. It's the rubber dam. It's been around dentistry for more than 100 years, so it's not something new. It's once the practitioners start doing it, it's a lot more comfortable. All the benefits of like all the visibility of the avoiding of the infection with saliva, also preventing the patient to get into their mouth the irrigation solutions that we use. They're caustic and they can burn their mouth. But also, and I will say the most important, actually, if a file or any instruments falls to the patient's airways, you can actually cause a very serious situation, even bring death to the patient from that. And there's no way that any government, there's no way any professional body will upset that situation. It's being published in the literature, patients being rushed to hospitals with files in their lungs. So it's not a matter of like, I have the technique, I know how to use it, I put a floss in my finger and I have the file, I have control. It just take a second for an accident. And that accident, like I say, will not only cost someone their professional license, but also it can also cost the life of someone. So, and that has no price. So it's with capital letters, the standard of care for doing a root canal treatment.
Thank you very much. Those last few capital letter words is what I needed to hear and what I needed everyone to hear. So rubber dam, rubber dam, rubber dam. There is, I think, a follow-up question from Dr. Bassel. So the crack would only be seen by transillumination, and RCT is the treatment to go if sensitivity has not been relieved by conservative approach.
Yes. Try to look in the literature if there's anything new. Like I said, there's varnishes, sometimes fluorides, sensitivity toothpaste. If we cannot resolve that, we go with a root canal treatment. I will, in a root canal treatment, evaluate very well the extension of those cracks. Sometimes what we have in the crown, depending the tooth, I don't know which tooth is, might be if it's an anterior, we sometimes see a hairline crack that we're able to see using the transit illumination. But there's cases in which we have to end up doing the root canal treatment. But we have to be very careful with that. Like finding out that the sensitivity, it's only on one tooth, that we decide to do the root canal treatment on that tooth. And it's not something more generalized, you know, when I end up doing a root canal treatment on a tooth and then having the patient with the same sensitivity. So there's patients that actually have that. There are patients in which I see sensitivity because they wear off their tooth with brushing, but it's what Dr. also Bassel says. It can be because from the crack, and a root canal treatment in that case will help out. There are cases in which we can do a temporary crown to see if this is something also important. Sometimes we have cracks. And the patient is having the pain, but we're doing the pulp testing. The pulp is responding normal. And we feel like, okay, the pulp is not being affected. It's not that we right away need to do a root canal treatment. We can actually restore the tooth with a temporary crown and see if the symptoms goes away, because the ferrule effect keeps the crown all together. And at the end, we might end up cementing a permanent crown. If after 1 month or 2 months, the patient is being chewing normally with a temporary crown, we might be able to cement a permanent crown, and that patient doesn't actually needs a root canal treatment for that.
That's great. I think there is one last question by Dr. Richu. The last irrigation to be used during RCT, is it hypochlorite, EDTA, Q-mix, or normal saline?
That it's I can say that it will be personal choice. I can say that because a lot of different clinicians will use different modalities. We don't like to have as the final the EDTA, but having some practitioners using the sodium hypochlorite as the last one, or using Q-mix or normal saline, all those three are acceptable. I will not post any preference. I myself usually end up with hypochlorite. A more, let's say, biological school will go more like having at the end saline. Or if you have the tooth very infected, there's cases in which probably my last one will be Q-mix. So it's I'm open to that. Which one I will not consider to be the last one will be just EDTA. Because with EDTA, what you're trying to do is like eliminate the smear layer. So you want to open up more those dentinal tubules. So if you put EDTA at the end, you even though the EDTA it limits itself, so it's not that it's going to decalcify completely the tooth. It's self-limited. You want to flush out all that smear layer or all that mineralized layer of that you have from the canals. You don't want to keep it incorporating in the obturation. So if you're going to use EDTA, you have to use either hypochlorite, Q-mix, or normal saline after it. Ideally, after the EDTA, you can use sodium hypochlorite, and you can have your Q-mix at the end. I would say in very infected cases, Q-mix is not a bad option to end up your case.
Thank you so much,
I have
Dr. Lewis.
one more question, if that's okay.
Yeah, of course.
All right. So this is a little off topic, but a few days ago, I had a patient who came from a different clinic, and she developed trigeminal neuralgia after maxillary endo, and she was asking me if it's related to the endo or it's just a coincidence, and my mind kind of went blank. I didn't know how to answer her, so if you can just talk about that topic just a little bit.
Personally, I haven't come up with any literature that says that trigeminal neuralgia will be caused after a root canal treatment. I don't see any relationship that either the patient had that before and didn't know it. That's different scenario. I don't know if this is the case, but have this or the patient has other kind of like let's say after the root canal treatment, any other kind of sensitivity or nerve injury or any of that, which like in this particular case, I don't know. But having the trigeminal neuralgia after a root canal treatment, know that I have read anything. And that comes from a back portion of the nervous system, so it's not something related to. No, they actually have to do a more comprehensive evaluation to see if the patient is actually developing other kinds of like nerve injury or sensitivity or any other neurologic response that is not necessarily thinking that. Is the patient that actually thinks that has developed that?
Yes, she does. She's convinced it's because of the root canal treatment, and I have no answer for her, to be honest.
No, I would recommend like definitely search into literature for all possible situations. But right now there's even in the Netflix documentary, there's a lot of information that patients are reading, and they sometimes want to try to relay whatever they're feeling. But trigeminal neuralgia is a very specific condition in which, like, if the patient, for example, touches face, it has a shooting, burning pain that goes along the nerve. So it's something that doesn't get to be triggered by a root canal treatment now.
Right. Thank you.
You're welcome.
Okay, now, again, I still have some iPhones and a number as your name. If everyone who is here right now can we'll take the next 30 seconds to a minute to type in your name as you want it written on the certificate in the chat, that would be great. Dr. Lubna, great job today. Dr. Lewis, thank you very much.
Thank you. Thank you, guys.
That was a full hour and maybe a little bit more than an hour of very useful, straight to the point information. Most of it are basic stuff. We always need the refreshers, and that's the essence of these article discussions that we will be having every 2 weeks. So in 2 weeks, who will present?
I'm
Okay,
off the hook now.
You're off the hook now. Yeah, I'll keep the surprise on the WhatsApp group and by email. But I think Dr. Aman already has a topic from Dr. Hassan, and I am thinking of someone else. I will surprise them by text. So if you write your name, feel free to leave the meeting. Okay, I think we have everyone. Thanks, everyone, and good night. I will copy all the names, send them to Fatima, and you'll be receiving the certificates by email.